Assalamualaikum doctors. In this video I am discussing cystic fibrosis management. So normally in cystic fibrosis patient we find jaundice, crayon, inhaler, portacath, these are. So it is an autosomal recessive conditions. Number 1, antenatal. Antenatal, it is chorionic villus sampling 8 to 10 weeks, amniocentesis 16 to 18 weeks. Postnatal, so antenatal are chorionic villus sampling 8 to 10 weeks and amniocentesis 16 to 18 weeks. Then postnatal and neonatal screening, we do the Guthrie test. Guthrie test looking for IRT, that is immunoreactive trypsinogen. So Guthrie test, what we looking for? Immunoreactive trypsinogen. Genetic testing, CFTR gene on chromosome number 7. So CFTR gene on chromosome number 7, sweat chloride test more than 60 millimole per liter. More than 60 millimole per liter. Criteria for diagnosis: asymptomatic positive IRT, gene test and sweat chloride test. So asymptomatic is positive IRT, immunoreactive trypsinogen and gene test and sweat chloride test. Symptomatic are plus positive gene test plus sweat test, 2 gene mutations or 1 gene mutation sweat test. So diagnosis of ABPA, that is allergic bronchopulmonary aspergillosis. So allergic bronchopulmonary aspergillosis, there is high eosinophils, immunoglobulin E, immunoglobulin G and positive culture sensitive for aspergillus. These are the diagnostic tests we are doing: antenatal and postnatal, Guthrie for IRT and sweat chloride test and CFTR gene on chromosome number 7. This is postnatal. Antenatal are chorionic villus sampling 8 to 10 weeks and amniocentesis 10 to 16 weeks. 16 to 18 weeks. Okay. Now investigations. Blood, we are doing full blood count, CRP, blood culture sensitivity, total immunoglobulin, specific immunoglobulin E for aspergillosis, random blood sugar and liver function test. Imaging and chest X-ray once per year. Other are sputum culture sensitivity more than 5 years. Spirometry for on admission, then weekly. SpO2 first 2 nights. Annual full blood count, blood film, urea electrolyte, vitamin A, D, E, parathyroid, RBS, total immunoglobulin E and specific immunoglobulin E for aspergillosis, Pseudomonas aeruginosa antibodies, bone profile, DEXA and GTT more than 10 years. Tobramycin, throw level before 2nd and 8th dose less than 1 millimole per liter. So other investigations are in blood, we are doing full blood count, CRP, blood culture sensitivity, total immunoglobulin E and specific immunoglobulin E for aspergillosis, random blood sugar and liver function test. Imagine chest X-ray once per year. Other are sputum culture sensitivity more than 5 years, spirometry on admission, then weekly, SpO2 first 2 nights. Annually we are doing full blood count, blood film, urea electrolyte, vitamin A, D, E, parathyroid, random blood sugar, total immunoglobulin and specific immunoglobulin E for aspergillosis, Pseudomonas aeruginosa antibodies, bone profile, DEXA and GTT. Tobramycin, throw level before 2nd and 8th dose less than 1 millimole per liter. False sweat test result. False positive are adrenal insufficiency, malnutrition, congenital adrenal hyperplasia, G6PD, ectodermal dysplasia, hypothyroidism, hypoparathyroidism, MPS and DI. Okay. False negative are dilution, malnutrition, edema, hyponatremia. Now what are the complications of cystic fibrosis we can find? Complications are: number 1, respiratory, asthma, sinusitis, nasal polyps, chest infection, ABPA, that is allergic bronchopulmonary aspergillosis. Cardiac are cor pulmonale, GITR, steatorrhea, failure to thrive, meconium ileus, distal intestinal obstruction syndrome and rectal prolapse. Hepatic are cholestasis, infancy, fatty liver, biliary cirrhosis and cholelithiasis. Pancreatic are insufficiency, pancreatitis, cystic fibrosis related diabetes mellitus. Metabolic are hyponatremic, hypochloremic, metabolic alkalosis and osteopenia. Others are infertility, azoospermia, needle phobia, that is trypanophobia and depression. So the complication of cystic fibrosis are again telling: respiratory are asthma, sinusitis, nasal polyp, chest infection and ABPA. Cardiac are cor pulmonale, GITR, steatorrhea, failure to thrive, meconium ileus, distal intestinal obstruction and rectal prolapse. Hepatic are cholestasis, infancy, fatty liver, biliary cirrhosis and cholelithiasis. Pancreatic are insufficiency, pancreatitis, cystic fibrosis related diabetes. Metabolic are hyponatremic, hypochloremic, metabolic alkalosis and osteopenia. And others are infertility, azoospermia, needle phobia, trypanophobia and depression. Management: immediate. What is immediate? Examine the child wearing my PPE. So I will examine the child wearing my PPE. Then ABC, admit, involve my senior consultant, relevant team, monitoring investigations. This is the management. Admission rule: discuss with the cystic fibrosis team before every decisions. Cubicle, BCC nurse in a cubicle in a separate ward from the other cystic fibrosis patients. So separate cubicle. And I will wear the PP. Then a long line or portacath will be inserted, flushed with the heparinized saline and mouth. So portacath we are inserting. Chest X-ray not routine. Only if suspected pneumothorax or lobar collapse. Chronic infection colonize more than 50% positive sample year, minimum 4 samples. Sputum culture sensitivity before starting antibiotics. Subsequent multidisciplinary team are cystic fibrosis team, cystic fibrosis nurse, dietitian, pulmonology, then PT, physiotherapist, GIT, endocrinologist, geneticist, social worker, psychologist, play therapist, that is needle phobia, that's why play therapist, and vaccination team. Again, the multidisciplinary team I am involving cystic fibrosis team, cystic fibrosis nurse, dietitian, pulmonologist, then physiotherapist, GIT, endocrine, geneticist, social worker, psychologist, play therapist, needle phobia, and vaccination team. Pulmonologist, IV antibiotics last used during exacerbation or first line regimen. Then nebulized antibiotics we are giving, oral antibiotics, prophylactic, bronchodilator, salbutamol, CPT, inhaled hypertonic saline, 7% postural drainage, PP, then vibratory jacket, new treatment, Ivacaftor. Then dietitian we are involving monitoring the height, weight, and BMI 3 months. Then diet at high calorie, high protein, overnight NG2 feeding, vitamin A, D, E, crayon plus H2 blocker. And also we are giving vaccinations and long-term condition follow-up, regular follow-up, avoid smoking, avoid trigger. Okay. So treatment are multidisciplinary team involving pulmonologist involving IV antibiotics, nebulization. Okay. IV antibiotic, nebulized antibiotic, oral antibiotic. 3 type antibiotic. Bronchodilator, CPT, and new treatment Ivacaftor. Dietitian involving. Immunization involving for vaccination. What are the treatment of complication in cystic fibrosis? So, first of all, DIOS, distal intestinal obstruction. It is an acute, complete, or partial fecal obstruction in the ileocecum. Okay. Acute, complete, or partial fecal obstructions. Symptoms are constipation, abdominal pain, distension, fecal mass. So, cystic fibrosis patient present with this constipation, abdominal pain, distension, and fecal mass. And diagnosis is CT, abdomen, management, mild macrogel and crayon, severe hydration, gastrography, bowel lavage, XR before and after failed contrast enema, then surgery. So management are we are doing constipation, abdominal pain, distension, and fecal mass can be present, mild macrogel and crayon, severe hydration, gastrography, bowel lavage. Now antibiotic choice. How can we antibiotic choice? Newly diagnosed, we are giving prophylaxis flucloxacillin, BID till 2 year, chest infection, cefuroxime. So flucloxacillin and cefuroxime. Now they ask about Pseudomonas aeruginosa. Pseudomonas aeruginosa, fast isolation, asymptomatic, Cipro 6 weeks, plus nebulization, colistimethate. Symptomatic tobramycin, ceftazidime 2 weeks, plus nebulization, colistimethate 2 months. Chronic infection, nebulized antibiotic, prophylaxis, that is tobramycin, inhaler form. So normally fast newly diagnosis we are giving flucloxacillin and cefuroxime, and as per when Pseudomonas and aeruginosa we are giving asymptomatic ciprofloxacin and nebulized colistimethate. And if symptomatic we are giving tobramycin, ceftazidime. Tobramycin we are giving nebulized form. Then the organism are Burkholderia capacia. Immediately report fast isolation, IV nebulization, antibiotic prophylaxis, tobramycin, meropenem. So Burkholderia capacia, then report immediately. Then Methicillin staphylococcus aureus, MRSA, report immediately. Fast isolation, asymptomatic nebulization, vancomycin for 5 days, 2 to 3 oral antibiotics for 6 weeks. Symptomatic IV antibiotic for 2 weeks. Chronic infection, oral nebulization, antibiotic prophylaxis. Aspergillosis or black sputum, isolated in the sputum culture, eosinophilia in CBC, increased immunoglobulin E, antifungal and steroid also. Aspergillosis, there is black sputum. The sputum is black color in aspergillosis. So treatment is antifungal and steroid. Now chicken pox. If no history of chicken pox and no antibodies, vaccinate. Okay. So only vaccination if no history of chicken pox, no antibodies. If exposure to a known cause, being in the same room for more than 15 minutes with face-to-face contact, immunostatus, history of chickenpox or antibody status before corticosteroids. If non-immuno plus high dose of oral corticosteroid, prednisolone 1 mg per kg per day for 1 month or 2 mg per kg per day for 1 week, exposure less than 96 hours, earlier request varicella zoster immunoglobulin. So if child is not exposed, then only vaccinate. If child is exposed occur, then immunoglobulin we are giving, varicella zoster immunoglobulin. If non-immuno plus modest dose of oral corticosteroid or higher dose, then give acyclovir. Okay, then if infected, if not taking steroid, give acyclovir, same dose oral for 7 days. If taking steroid, discuss varicella zoster immunoglobulin with microbiology consultant. Extra vaccine, influenza vaccine every October, conjugate pneumococcal vaccine. So mainly chicken pox rule in cystic fibrosis I am telling. If it is not anything, no any touch, no taking steroid, then it is vaccinate. If the child is taking steroid and with close contact, then we give varicella zoster immunoglobulin. If there is symptoms infected, then oral acyclovir. If severe, IV acyclovir. And the antibiotic choosing again, prophylaxis we are giving flucloxacin, cefuroxime. If aspergillosis, Pseudomonas aeruginosa, we are giving ciprofloxacin and nebulized cholestyramine first, then tobramycin in nebulized tobramycin. Then the Barkhoderia capacia, then we are giving nebulized antibiotic tobramycin or meropenem. Then MRSA we are reporting and also giving nebulized antibiotic. So everywhere we are giving nebulized. Vancomycin here we are giving. Aspergillosis we are giving antifungal. There is black